Our next series of debates is going to take on Dr. Kavita Rao, a prolific cornea surgeon from Aditya Jyoti Hospitals, Mumbai, who's going to tell us why topical therapy should suffice in severe ocular allergies. And she is going to be challenged by Dr. Vinay Pillai, a senior consultant and head of the Cornea and Refractive from Giridhar Eye Institute, who is going to tell us that the role of systemic and topical therapy is what is needed for severe allergies. So let's see how interesting this debate gets. On to you, Kavita.
Thank you, ma'am. Are my slides visible?
Yeah.
Great. So I'll just broken down my talk in these few categories. First, we're just starting with what are the types of allergic eye diseases, because we've just mentioned allergic eye disease. We've not really mentioned which one. And also, I think the second point, defining what is severe ocular allergy, becomes very important for this debate, because we specifically said that we are going to be debating it about like the use in severe ocular allergy. The third point I'd like to bring about is like the periodicity of the allergy. Like the patient may have a severe allergy, but how periodic it is, that is important. And then, of course, we move on to the type of steroid sparing agents. And then the last point, or the most important point of the debate, is as to whether we are going to use only topical or topical and systemic combined. Now, allergic eye diseases, as we all know, there are four types: seasonal and perennial. These are type 1 hypersensitivity, and the VKC in atopic keratoconjunctivitis is the type 1 along with type 4 hypersensitivity. I think we would agree, all of us here, that seasonal allergic conjunctivitis, we do not see severe cases at all. These are mostly mild and self-limiting. Now, VKC is where we are going to be seeing severe cases. They're essentially of two types, three types: palpebral, the limbal, and the mixed variety. And atopic keratoconjunctivitis has features similar to VKC, but along with sometimes lid margin thickening, much more severe corneal features, and the atopic dermatitis. In 30% of patients of atopic dermatitis, we see features of atopic keratoconjunctivitis. So now moving on to my second point, that let's define what is severe ocular allergy. Now VKC, as you saw, there's a spectrum of presentations from just palpebral like the disease to shield ulcers to ultimately a limbal stem cell deficiency. The Bonini VKC severity score, which was put forward, this was very vague. They defined that the disease is severe if there's ocular symptoms with photophobia and with corneal lesions. They did not look at any specific corneal findings. They did not also look at the periodicity of the disease. Our very own Dr. Gokhale, he has published this. Here, what he has done is he has broken down the findings, and if you see, you look at the findings, depending on the presence and absence of your corneal findings, he has broken down the disease into mild, moderate, severe, and blinding, and also depending on how periodic the disease is. Is the patient getting the disease, is it consistent throughout the year, or is it for a part of the year when he's off medication? Now, if you see, in the patients with shield ulcer and limbal stem cell deficiency do not fall in severe, but he's actually put it into the blinding part of the grading of VKC. Now, this is again where he has published this, where he has said that if there are giant papillae and macro erosions, if the limbal involvement is more than 180 degrees, this is our category of severe disease. So the debate, essentially, I'm going to focus on these category of patients with VKC. Now, this I think would then probably fall into VKC because this patient has macro erosion, has extensive limbal involvement. Shield ulcers, of course, though we could debate that according to the classification, it goes into blinding VKC, but let's still consider that it is a severe form of VKC. Now, LSCD or limbal stem cell deficiency, this was first published by Dr. Sangwan, where the association of limbal stem cell deficiency along with VKC, this definitely falls into a blinding form of VKC. Now, let's move to the next point, which is periodicity of the allergy. Now, if there's intermittent disease, that means the patient has free intervals where for 2 to 3 months, when he's off the medication, he's not having the disease. And chronic disease periodicity is when, if he's off the medicines for less than even a month, he again gets all of the symptoms. So this is very important because here we'll know that some of these patients actually year-long they are suffering. Okay, so now let's move on to the next point, which is what are the steroid-sparing agents which they want us to debate about. So we can divide that into topical and systemic. Now, for sake of completion, I've included everything. But I think all of us here would agree, like the first two, which is the antihistamines, the mast cell stabilizers, whether it is topical or systemic, they're not really going to work in patients with severe disease. But though we are going to give them as a combination, but they're not really going to be of help, like, any help in exclusion. Now, the third category, which is the calcineurin inhibitors, they're either cyclosporin or tacrolimus. Now, cyclosporin is commercially available as 0.05% to 0.1%, but higher strength can be made by using this injection cyclosporin. And I've used this in artificial tears, and it really works really well. This is the, I think this is the first case report. And this is another, patients, like very large cohort where 197 children have been studied, where 1% topical cyclosporin was used. And these patients were off the steroids, and the patients did really well. This is another patient, large series with 156 patients with severe VKC, where patients have done well. Now, this is again looking at the safety of topical 2% cyclosporin, and this is another study where 0.05% again is was studied. Now, moving on to the next, non-steroidal, which is tacrolimus. This, I know a lot of people are very resistant to use it because patients are not very compliant. They complain of burning, even with the ophthalmic preparation. What we can do is the transdermal application. You ask the patient to just put it on the margin of the lid. They do tolerate it well. Though, because FDA came up with, issuing, a risk of, neoplasia with this, I know it is on the back burner, but like off-label use, I think most of us are definitely using this. It really works well. This was the study which I found. There was a 3-year follow-up with patients with only the ointment being used, and patients really did well and on maintenance of this ointment. And this is a double masked comparison of tacrolimus with 2% cyclosporin eye drops in severe vernal keratoconjunctivitis in children. It was well controlled. Now, none of these in studies anywhere, like any that systemic immunosuppressants or systemic non-steroidal agents have been used. Again, this shows that the treatment of refractory anterior segment inflammatory disorders, including patients of VKC. Now, like moving on to the last point, whether what is the need for systemic non-steroidals, or should we be using only topical? This was a review paper which has been published in Allergy. Here you can see that they actually start out with which I have mentioned, that start out with using your antihistamines, use your mast cell stabilizers, and use your topical cyclosporin or tacrolimus. Only in patients where it is recalcitrant and like in the blinding diseases, even in atopic keratoconjunctivitis, it's only reserved for those patients. Now, I'd also want to offer another viewpoint. Like this, moving on to this, Dr. Gokhale has also published this, where the role of oral is cyclosporin. There's no role of oral cyclosporin in severe VKC, but in blinding diseases. Now, again, another viewpoint, he's also published this similar thing where he's talked about a step ladder algorithm, where, as you can see, that there is really no role for oral oral immunosuppressive in the severe category of allergic eye disease, which is what we are debating here. Now, even if you consider the blinding kind of VKC, which is supposedly your shield ulcer, here, even in these patients, there is no role of systemic immunosuppressants, not to the best of my experience, because most of them will work well with doing your excision, with using AMG, supratarsal steroids, and keeping them on topical immunosuppressants. These are all patients where they have been managed with just using your topical therapy. No systemic therapy has been used. So I'd like to conclude that I think topical steroid sparing agents, they effectively treat and control severe ocular allergy, and the role of systemic steroid sparing agents would probably be only in the recalcitrant and in the blinding cases of especially atopic keratoconjunctivitis, and maybe a very few patients, a handful of patients of vernal keratoconjunctivitis. Thank you.
Thank you, Dr. Kavita, for detailing us about the topical use over oral. So we will stop sharing your screen.